And a very good evening to you. I am Lisa Lord, and my special guest is the head of the Rehabilitation Department here at the Queen Elizabeth Hospital, Dr. Harley Moseley III. Dr. Moseley, thank you so much for joining us on the program.
Good evening, Lisa, and thank you very much for having me.
You're most welcome. Now, I want to start in very broad terms by looking at the role of the physiatrist and your team here in the Rehabilitation Department.
Well, before we even start there, we need to understand what is rehabilitation. And essentially, to go back to the old Latin root of habilitas, meaning to live, and rehabilitas, or to give back one life, rehabilitation is simply the science of getting the person back to an area or functioning to their maximum ability, independence, as well as having the maximum quality of life. So in doing that, the area of rehabilitation medicine now aims at getting the patient and the person to their optimum functioning in spite of the damages that may have been caused by the ravages of disease or injury. And as a result of that, a practitioner who does this, or a physician like myself, is known as a physiatrist, because this is under the area called physical medicine and rehabilitation. And as a physiatrist, when I see patients, I aim to bring them not only to their optimum quality of life, but also to give them their independence. But I do so with the work of a team, and the team behind me. And the team consists of therapists, such as physiotherapists, occupational therapists, speech therapists, and also, in the case of our department, a prosthetist orthotist.
On a weekly basis, on average, how many patients does the department see?
Well, Lisa, I would have to break that down on a day-to-day basis.
Sure.
Because we have different segments in our department. The physiotherapy department, for example, sees well over anywhere between 90 to 100 patients per day, both outpatient and inpatient. The occupational therapy department runs roughly anywhere between 15 to 20 patients per day. The prosthetics and orthotics, if we split it up into orthotics alone, it runs anywhere between 10 to 20, with the amputee clinic seeing anywhere between 6 to 12 patients a day. So we're a busy little department.
A very busy department. I was not expecting those numbers at all. Now, Barbados unfortunately has a high incidence of diabetes, since we're talking about numbers.
Yes.
We know that this NCD sometimes results in persons losing a limb or two.
Yes.
So you lose a leg, you lose toes, might lose fingers. Persons also lose limbs as a consequence of accidents.
Yes.
Whether they be vehicular, workplace, what have you. Let's look at rehabilitation for persons that have lost limbs, amputees, because we do have an amputee clinic here within the department.
Well, I'm pleased to announce, even though it is a pretty grim topic, that we opened up the very first fully staffed amputee clinic in the English-speaking Caribbean in 2006 when I returned. And that would include, the only thing that we're missing based on international standards would be a psychologist. And as a result of that, we have been able to revolutionize the care of amputees over 16 years. And it may seem to be a lengthy process, because I understand that sometimes patients do get frustrated in how long they have to wait, but there are necessary steps that they have to undergo.
And steps like?
Well, one of the things is, as you very rightly mentioned, majority of the patients who present to our amputee clinic have lost their limbs due to what we call dysvascular diseases, which means that their blood flow or blood circulation to their limbs has been compromised in some form or fashion, whether it's due to diabetes, hypertension, or the ravages of atherosclerosis. And as a result of that, what has happened is that they either get an infection by stepping on a nail due to improper footwear, and they get gangrene, and as a result, for a life-saving measure, they have to undergo an amputation. So one of the problems we have with these patients, or the issues they have, is that if you have blocked circulation in your legs, you may have blocked circulation elsewhere. And that puts you at a risk for heart attacks, strokes, and other things, other organs that require high blood flow, such as your kidneys. So as a result of that, in the amputee clinic, one of the first things we do is assess the patient to see if they are cardiovascularly fit. In other words, is their heart fit enough to take a prosthesis? Because after all, the prosthetic or the artificial device that we put on, in this case, we'll talk about lower extremities, is often heavier than the one that you were used to or born with. And as a result of that, it can precipitate heart attacks or even make patients tired. And we've had one or two cases every now and again where the prosthetic has been a little too heavy for the patient and they don't use it.
Let's talk about the prosthetics.
Sure.
A lot of people complain that they're not easily accessible and they're also expensive.
Yes. Well, that is a bugbear of the department. The rehabilitation department is one of the few departments in the hospital where we have a public-private arrangement where the hospital and the government of Barbados is responsible for the patient's health, but the prosthetics are provided primarily by private companies. There is provision for a public company, but unfortunately, due to issues of procurement and the fact that we're unable to get supplies readily, we're unable to produce the public or develop the public service with regards to providing a prosthetic. So what has happened is that when it came back in 2006, there was one company that was providing prostheses. And as you know, when you have a one company situation, you can raise or lower prices at a whim. But now we've tried to encourage at least some degree of competition. And as a result of that, because there are now about three, their prosthetic prices have stabilized so that arguably for lower extremity prosthesis, you can run anywhere between $4,000 to $6,000. And for an above knee amputation or prosthetic for above the knee, the first one was a below knee,
Right.
sorry. And for the above knee, that runs anywhere arguably from $9,000 to $10,000 or above, because the cost of a prosthetic depends on the components it's made of.
Right.
You know, we can either make it very simple or we can make you like the $6 million man, literally.
Yeah. So it is expensive.
Yes.
Barbados has some gloomy statistics regarding strokes as well. We are recording, I think the last available information was about 2 strokes a day.
Yes.
Those strokes can range from very mild to more severe. In some cases, persons have paralysis and they encounter mobility issues. So let's look at your team and how your team works with persons who would have suffered strokes.
Okay. Well, strokes is another bugbear that we have. As we rightly said, 1 to 2 strokes a day. And not all of them are admitted. We tend to admit the ones who have residual impairments or effects from the stroke lasting more than 24 hours. Ideally, in the future, we have been advocating that all strokes should be admitted and observed for a period of between 24 to 72 hours. But, however, given resources, we've had to do what we've had to do. Now, having said so, Barbados has also set up a stroke unit, which in the stroke unit, the aim has been to provide acute medical care, which means that we stabilize the patient, provide early rehabilitation, and as a result of that, we also enable safe discharges. But we've tried to put it all under the same ward. So in other words, there's no time limiting factor for the patient to get the baton of care passed, for want of a better term. And as a result of that, we've managed, for example, since the stroke unit has opened, we've cut the amount of deaths with regards to one of the complications from stroke, and one of those was aspiration pneumonias. Before we started the stroke unit, the incidence of aspiration pneumonias was something between 22 to 28% per stroke patient. we've actually got that down into single digits as a result of the stroke unit. And it's been shown internationally that patients who are admitted to stroke units have a longer life at 1 year intervals, and also are more independent and also happier in terms of their quality of life.
In terms of the interventions used for those with mobility issues as a consequence of the stroke, are you happy that enough is being done in that regard?
Well, 7 years ago, we opened the stroke unit, and at the time, we were almost fully staffed. We had the nursing, we had the neurologist, we had the physiatrist, myself, we had the consulting physicians, including a neurosurgeon, and we had the various therapists. We had 2 occupational therapists and at least 3 physiotherapists and 2 speech therapists at one point in time. As time has gone on, the stroke unit has unfortunately lost a lot of the members of it with regards to the staff. So as a result of that, now we are limping along right now with 1 occupational therapist, 1 speech therapist, and we have some augmented physiotherapy with regards to both the public and the private, public and sessional physiotherapists that we have hired to provide care for the stroke patients. But unfortunately, it is not enough. We need more. We need more support with regards to that in order to provide safe discharges for patients and to make both the patient and their caregivers happy.
Outside of a lack of human resources, what is the biggest challenge when it comes to treating someone that had a stroke? Is it a case of somebody not wanting people to see them coming to rehab? Because there is a stigma attached.
The biggest problem we have, at least from the stroke unit, is that the relatives, particularly the families, feel unsafe taking their relatives back home. They seem to think that they cannot cope with the problem, because here you have John Brown, who used to be the family breadwinner, up to 68, was still going down to town and playing dominoes with the guys and stuff, and was married or had a spouse at home, and they were living quite happily together. And now when you see him in the stroke unit, or they've seen him have the stroke, he's not talking properly, he's not thinking properly, his hand may be limping to one side, he's unable to walk, and maybe needs help going to the bathroom, or is not able to go to the bathroom by himself. And as a result of that, the relatives get intimidated and they get scared. And one of the purposes of the stroke unit, which we're now trying to actively combat, is education of the caregivers, because we want people to know that having had a stroke, patients can go on to a new life. Okay, it's not that it's the end of life, but it's just a matter of adaptation.
Barbados unfortunately records a number of vehicular accidents as well, and persons are also injured in various ways through shootings. Let's look at spinal cord injuries, and are they frequent? Are you seeing more than, let's say, 10 years ago?
Spinal cord injuries, I am actually, again, one of the few things I will say, happy to report are relatively rare. Okay, we get anywhere between 3 to 4 serious spinal cord injuries a year. However, unfortunately, a spinal cord injured patient is probably the most dependent patient that we can have in a medical system, depending on what level of the spinal cord has been injured. If you have lower level spinal cord injuries, you can deal with paraparesis and paraplegia, where they're unable to walk easily, and you have issues with maybe a wheelchair or 2. But the higher up you go, it is the more the body is affected. So when the very high spinal cord injuries that affect the neck, where you have broken necks, they can affect not only all 4 limbs, both arms as well as the legs, but also they may affect their diaphragm, which is the muscle for breathing.
Yeah.
And sometimes some of these patients require ventilation. And as a result of that, a spinal cord injured patient can run anywhere from a ventilated, totally dependent on nurses for bodily functions, whether it is to stool or urinate, And they can't move or scratch, and they're basically prisoners in their own body. All the way down to maybe paraplegia and unable to move themselves. And the sad thing about this is that it seems to affect mainly young men. Young men are, in terms of the ratios, overwhelmingly affected more than young women or women of any other age group. There's also another peak in the older age group where you have the little old person, again, usually an old man, going to the bathroom. It can occur with old women too, but again, it's predominantly male. But they go to the bathroom and they slip
Yes.
and fall. And as a result of that slipping and falling, they hit their head and on the toilet bowl, and they get what we call hyperextension of the neck. And that can cause paralysis of all four limbs as well as the diaphragm. So what is concerning about this condition is, even though it is rare, it is quite expensive, as you can hear. And you need nurses, you need therapists, and when you're looking to be discharged, you have to adapt your home. I've had patients who've had to buy new houses in order to be moved home. And it can also affect the person psychologically as well. Even though it is, in the past, it used to be said that, or assumed that all patients with spinal cord injuries were depressed. It's actually a little less than that. They've shown that about 25% of them are morbidly depressed. Some will get over it and accept that this is a new way to live. And as a result of that, they will continue with life. I've had patients who have continued and have had children. But one of the things that I would like to get across, if anything at all, is that it's also quite preventable, particularly with the young men. Spinal cord injuries are most common in young men who dive headfirst into the water. As you've seen 3-4 weeks ago with the young man who was an athlete.
Unfortunately.
Yes. And I take this opportunity, if you don't mind, Lisa,
Certainly.
to warn everyone that if you're going to dive into water, unless you are sure that it is 10 feet or greater, or rule of thumb, it's twice the length of your height, that you should dive foot first on the first dive. Particularly here in the sea and the jetties, where just because it was so last week doesn't necessarily mean it's so now, because you can get sandbanks developing overnight. The other thing, of course, would be to encourage the use of seatbelts, because there have seen a rise in young men now saying that they're not wearing seatbelts. Car accident, seatbelt, that is one of the most common ways of breaking your neck. And in our population, I'm sad to say, but I'm still hearing anecdotes. The young men love to show off, whether they're girls on the beach or they're showing off with their friends, and they like to do these no hands flips on the beach, and you land badly on your neck. I've seen one unfortunate individual like that recently, and as I said, it's taking the individuals at the prime of their lives. We're talking about adolescent males, we're talking about 14, 18, that sort of age, and it's heartbreaking to see them in the hospital having to know that they're no longer going to be able to necessarily ever walk normally again. That being said, I know I'm being a bit long-winded.
No, that's fine.
But I've had patients who have adapted to their spinal cord injuries, and as a result of that, there are a couple of individuals that I will mention without mentioning their names. I've had one spinal cord injured patient went to the University of the West Indies. After the injury, he was able to enroll, and he got a first class honors in finance and banking. Obviously, I think people would know who he is, but I'm so proud of him. And then there's another one, again, who also, he completed his studies at Samuel Jackman Prescott, and he has done extremely well. No, but having said so, they are 2-3 years out of the system and they're unemployed. First class honors from UWI, and you don't have a job. That's unheard of if you were a normal, able-bodied individual. And I have other patients who are, for want of a better term, paraplegic, who've had issues with walking, who one of them who will remain nameless, but I know this might identify him or her, who's enrolled in medical school now and is doing extremely well. So, in other words, I say that all to say that spinal cord injuries does not mean the end of life. It just simply means adapting and
Living differently.
living differently. Yes.
I want to go back to something you said, these spinal cord injuries that occur when the driver does not wear or the passenger does not wear a seatbelt. Naturally, if someone is in an accident, persons passing by might want to assist, but we've also been told you're not supposed to remove that person because you can actually cause further injuries.
Yes. And that is absolutely great advice. Unless the car looks like it's going to blow up when you smell gasoline, it is advisable that if you're going to try to move the patient, even then, if you're going to try and move the patient, you stabilize their neck. There's a very infamous case in the past
Yes.
where we all know about a motorcycle accident where the guy removed his helmet and that was the end of that. So yes, that is absolutely great advice there. And then one last thing on the topic, I will just very quickly say, I say that spinal cord injuries are preventable because simple things like signage on the jetties or recurrent public message every year during summer when young males and adventurous young females are flipping and diving off jetties, to reinforce this message, I think would help to cut the numbers down. And it is my dream to possibly never see another spinal cord injury again, if possible.
And I just want to be clear. You said you record about 3 to 4 serious spinal cord injuries every year. Of those 3 to 4, what's the main cause?
Main cause is young men diving.
Okay. Well, we'll take a short break. Stay with us. Still a lot more to discuss. You're watching One on One.
As Barbadians prepare for the Atlantic hurricane season, here is some information about shelters. Shelters are listed in 2 categories. A Category 1 shelter may be used during a hurricane or other hazard event, while Category 2 shelters may be used if they are still in a reasonable condition after a hazard event or disaster. Persons are advised to make their way to shelters well in advance of a storm's arrival.
Welcome back as we continue our discussion with the head of the Rehabilitation Department at the QEH, Dr. Harley Moseley III. Dr. Moseley, we spoke about a couple of injuries that you see here at the Rehabilitation Department.
Yes.
We focused in the latter part on spinal cord injuries. Let's look at traumatic brain injuries from those same incidents, whether it be diving, car accidents, shootings, etc.
Yes. Those are actually more common and associated with motor vehicle accidents, especially as we reiterated just now, the seat belts, which I understand is not always comfortable for a lot of people, but please, I beg you to get a pad and wear them at all times. But traumatic brain injuries can run anywhere between mild, moderate, or severe. In other words, how much of your brain has been injured. And we usually try to admit moderate and severe brain injuries to the hospital. But our biggest bugbear right now in our society would be the mild traumatic brain injury. This is the sort of injury that occurs during, for example, a football game, which happened recently, where 2 players collided with each other, or little children running around and they fall. And you may not think of this as nothing, or a workman at work site not wearing his helmet, and somebody accidentally a hammer slips out and hits him in the head. You go to the accident emergency or the polyclinic, and you say, "Oh, you have a little headache," and they send them home, or with some Panadols or something, some light form of pain-killing medication. But what people don't observe, except unless you're close to the person, is that the person may start to forget things, or they may start to have consistent headaches, They may start to act strangely. And these are what we call concussions, mild traumatic brain injury or concussion. And a lot of has been made about it, for example, in the United States with the game of American football.
Yes.
In spite of all their protection, they get a lot of concussion injuries. And why is it so important? Because concussions affect how the individual thinks or relates. You may have a child that fell and was coming an A student, suddenly coming 27th or 28th in class. Or, for example, a workman who is so used to with measurements and is very good with numbers suddenly can't calculate the change that you give him or buy a newspaper. So these are the injuries that we have to watch out for. And one of the things that we've done at the Queen Elizabeth Hospital is that along with myself, I run a concussion clinic with the Department of Pediatrics as well as the neurosurgery department for these mild traumatic brain injuries. And what we try to do is we try to address what we call the thinking dysfunction or cognitive dysfunctions by sending them to occupational therapy to make sure that they can do their day-to-day tasks of living, because some people will get hit in the head and they'll forget how to dress themselves, or they will just stand there and not know where they're going. We address how they communicate, because again, that mild injury may affect their memory, and one of the remits of a speech therapist is also includes his memory and memory aids. And as well as we don't have it available in the public system, but if we can get them to pay for private consultation, we'll send them to a neuropsychologist who will also help to map out what are what we call the functional issues with the patient as a result of this mild traumatic brain injury. That is one that is easily missed. But the ones that have been admitted to hospital, we automatically follow them up for what we call thinking or cognitive dysfunction.
You mentioned children playing and falling. You mentioned motor vehicle accidents. What are some of the other incidents that would trigger a traumatic brain injury?
I did mention sports, and
Yes.
sports are the big one. Especially given the fact that we like a lot of cricket here, and some people like to go with a helmet that has not been changed for like 3-4 years, and they're going to face Mr. Big Boy Jones, and he's bowling bouncers, for example. Football, particularly younger children, they're very susceptible to concussions, and in some countries they're not allowed to head the ball below a certain age because of repeated head trauma. And also the fact of if you suspect an athlete has concussion, we tend to be very, 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 very careful about sending them back to the field of play. Gone are the days where, the movies where, they need, a saving pass or a saving strike from the injured player who comes out and wobbles onto the field and think. No, we don't encourage that, because what happens after the game, because we don't have any professional leagues here in the island, a lot of these semi-professionals and amateur athletes have to go back to jobs. And how do they function in their jobs? And that's something that we need to focus more on. Other than that, mild brain injuries, those are the big areas there. The semi-contact and full contact sports, the motor vehicle accidents, and the falls.
In looking at concussions, do you find in some instances persons take too long before they come to the hospital? And when I say that, I mean, okay, I fell, I hit my head. It's natural to probably have a severe headache. That headache eases. In another 2 days, it comes back. I have some blurred vision. But again, I know that I'm attributing this to the fall, but I am lagging in terms of going to seek medical attention.
I think that, unfortunately, by the time most individuals, particularly men, again, say, it's just a mild headache, they tend not to come to the hospital at all. And it's often on the urging of somebody close to them that they go and seek a doctor. And this is one of the areas which may even linger so much in my experience that it's brought to my attention by a lawyer and not even a doctor, because the patient has had something happen to them at work. Nobody's taken it on. The company doctor has said, "Oh, okay, it's just something. You can take some Panadols," and nobody has noticed that Mr. Jones or Miss Williams, who's very good managing cash, is suddenly miscounting, or is not able or is very short-tempered and moody, where they used to be jolly before. So it's an area that is easily missed, and it's something that we have to be highly suspicious of when you have any form of head injury.
Unfortunately, we also have a fairly high number of heart attacks. We have persons with heart conditions as well, persons that might be wearing some device, a valve, etc. You have persons with respiratory conditions. And you also provide cardiopulmonary rehabilitation here as well.
In conjunction with the Heart and Stroke Foundation of Barbados, to some degree, we do cardiac rehab here in the hospital, and when we get them to a certain point, we then encourage them to go to the Heart and Stroke Foundation. Now, having said so, cardiac rehab is where we try to not only get the patient more fit with regards to their cardiovascular fitness and stronger, but also get them used to the condition, because they have to adapt.
Yeah.
Okay, and they have to understand that this has occurred, and it's along this stage of recovery that we emphasize secondary prevention. And as a result of that, with the therapist, we take them through their various exercises, but we also try to change their diet. And we also try to make sure that they stop smoking if possible. And unfortunately, there's a common myth in Barbados that if you don't smoke tobacco, you're not smoking. But smoking includes all substances. Stop smoking. Okay? I hope I get that through to everybody.
You were forceful.
But nonetheless, having said so a cardiac rehab program is where not only a rehab program that focuses on strengthening, but is also lifestyle changes as well and modifications. A pulmonary program is a little different.
Yes.
in that a lot of patients who have pulmonary disorders such as asthma or even chronic pneumonias or obstructive pulmonary diseases, they are unable to walk distances that you and I take for granted, like from the bedroom to the bathroom without puffing. And as a result of that, with a pulmonary rehab program, we try to emphasize more exercise to increase their stamina. Now, why we lump both of them and call it cardiopulmonary rehabilitation is because in this form of rehabilitation, we're emphasizing the building or increasing the number of mitochondria. Now, this is the most medical that I will be here, but mitochondria are simply those little engines in the cells that convert the energy liberated by burning oxygen when you take in and breathe and convert it to energy that your muscles can use. So that's what we try to do, and that's what increases your stamina.
And like I said, we hear a lot more about heart attacks and heart conditions, but are you seeing more persons with respiratory conditions having to come to the rehabilitation department?
Well, initially I would tell you no, but guess what happened? Over the last 2-3 years,
Yes.
we had COVID.
COVID.
And COVID not only causes pulmonary conditions, but it being more of a systemic disorder associated with a lot of inflammation causes other things as well, because it can also precipitate heart conditions as well as neurological conditions as well. So COVID has factored in, and one of the things that occurred early in the COVID epidemic, which I would have to mention, was that when patients were being admitted up to Harrison's Point, they had noted that they were spending a fair amount of time there, and they wanted to decrease their bed stay time. And one of the ways of decreasing it was through therapy. And we sent a couple of therapists there. And as a result of that, that has increased our workload in the department almost by, at least I would say off the top of my head, between 30 to 40%.
So you are seeing long-term COVID effects?
Well, we're seeing acute COVID infections that require rehabilitation. But theoretically, it's been shown that in any population, 10 to 15% of the population will have long-term COVID effects. But I'm not quite sure that it has not been fully well defined, but as of an article I was reading in Clinics of North America, August this year, they have not only shown that the 10 to 15% of long-term COVID effects, but they also increases the presentation of non-communicable diseases in their end stages. So you will get more strokes, you'll get more heart attacks, and it is my postulate that that is one of the reasons why we've had increased numbers in the accident emergency department.
Are you also treating patients with fibromyalgia here?
Oh yes, oh yes. You're now coming to chronic pain. Those are what we would call the chronic pain patients. And fibromyalgia is one of those diseases that, for want of a better term, it has been controversial. But over the last couple of years, it has been classified now. There is a theory going around that it may be due to what we call nociplastic pain.
Break that down for me, please.
I will break that down for you, Lisa.
Thank you.
Basically, if you have pain, your brain will say, once you're in pain, it will send out impulses to modify that pain or to make the body feel less pain so that you can get out of the whatever situation is causing you the pain, the so-called flight or fright. Okay? What happens in patients who have been in pain for a long period of time is that those impulses slow down or may actually stop. And as a result of that, there is no mitigating or ameliorating impulses coming down from the brain to say, okay, we're in pain, but we need to calm down. So as a result of that, now the pain continues unabated. And as a result of that, it may not only reflect itself by becoming more generalized, but it may also reflect itself with nausea, anxiety, lack of sleep. Okay, and as a result of that, the treatment of something like fibromyalgia and other things are similar to that. Migraine headaches have also been shown to be nociplastic in nature, as well as also TMJ dysfunction or temporomandibular joint dysfunction. My dental friends will probably laugh at the TMJ, but yes, temporomandibular joint. It's a joint here that opens and closes the mouth. Right. And it can get dislocated or shifted in a way, and it can cause headaches in its own self by being a pain generator. So that can also cause pain, and that is thought to be nociplastic as well. So it's a theory going out there right now, and I am one of the believers of that.
Dr. Moseley, earlier we discussed at length spinal cord injuries, but we didn't touch on that condition affecting the spine, which is fairly popular, unfortunately, known as scoliosis. And in children, we are told that a lot of times that's caused by the heavy bags they carry their books to school in.
Well, scoliosis, that is abnormal curvature of the spine. It may be functional or it may be structural. And by functional, we mean that you could have pulled a muscle, and that could obviously come from the heavy book bags. And I can understand why that may have been a common belief. But the things that we have to watch out for are the congenital, or the persons who are born with it or have a tendency for scoliosis. And as a result of that, their spine starts to curve as they get older. We call them the adolescent idiopathic scoliotic patients. And what my department does, because these patients are predominantly seen by orthopedic surgeons, but we are responsible for exercise, because some exercise in terms of working on the muscle imbalances that may have been caused by the spinal curvature, and also the bracing, where we try to emphasize bracing depending on how much the curve is and how mature the person is. So if you're still growing, for example, you're more likely to have an increase in your curve than if you're not. So we tend to brace between 0 to 20 degrees, okay, of curvature. But greater than 20 degrees, we're now looking at surgical correction. And the other thing we look at as well, besides the actual spine as itself, is that we also look at how the person is walking, because that curvature can affect the length of your legs. And this is also the department that deals with the footwear that we would give to correct that leg length discrepancy. Okay, so we work in conjunction with orthopedic surgeons just to get it, and they decide, along in conjunction with us, which patients are mature enough to require surgery or immature enough, and they may want to slow the rate of growth of that curve of that spine, and they require bracing. All right, so it's, for want of a better term, it's a multidisciplinary approach again. And it involves often these uncomfortable braces, particularly for a lot of children who have curves and they're too young for the surgery. But it has a good outcome once patients remain following instructions and using the braces as we have directed.
And I just want to make sure that I didn't speak out of turn, because I said it is a popular condition.
Well, I wouldn't say popular. It's a little uncomfortable, but
Popular
yes,
in the sense that you're seeing more cases of it.
I understand where you're coming from. Is it we're seeing more cases, or are we now looking for
Diagnosing.
it? Yes, and I think what has happened is that when I came back in 2006, they were continuing a school program at one point in time. I'm not quite sure if it's still going on, where we were trying to encourage even the physical education teachers to look for these curvatures and send them to the nearest medical or clinician clinic where they could be assessed. So it might be a fact of both, but I would have to ask my orthopedic colleagues.
I'm sure looking at me, you can tell that I'm not sitting properly. Something that many of us are guilty of, our posture. And I know that the department offers ergonomic assessments as well to make sure that workplaces, for instance, they have the proper chairs, ergonomically friendly chairs for their employees.
Yes, actually, this is a little known fact about our department. In fact, one meeting I initially had with the higher ups in the hospital, they were actually going to hire out and ask for professional assessments of the offices of the hospital. And when we had to point out that this is one of the strengths of the occupational therapy department, this is what they do. This is what they're trained to do. An occupational therapist comes in, make sure that your workstation is comfortable and that you can function as best as possible. As well as there also is some overlap with the physiotherapist as well. So we have both therapists that can do an ergonomic assessment. And it's something that we're undersubscribed for want of a better term. And it's something that we can offer as a department.
Well, I'm sure you will be oversubscribed shortly now that more persons know about this service.
Sure.
So, and looking at the services offered here in the rehabilitation department, I'm going to show a little bit of bias here.
Sure.
And say that I'm very pleased to know that you are focusing a lot on women's health. In terms of pain management, so we're looking at painful periods, endometriosis, stress incontinence, which happens when something as simple as coughing, laughing, sneezing puts pressure on your bladder.
Yes.
You deal with all of these things here?
Yes, we actually have a specialized physiotherapist in the department who's again another one who is subscribed, but as a result of that, stress incontinence, for example, occurs because muscles are weak.
Yeah.
And one of the strengths or the aims of physiotherapy is to strengthen muscles and to, for want of a better term, exercises and coping mechanisms that you can deal with it. Also, areas of endometriosis or pain, that is kind of multidisciplinary. Not only do you do the physiotherapy for the exercises to help to release your body's natural pain-killing substances, we call them endorphins and enkephalins, but also there's myself in the department to give any supplemental medication on prescription. So it can go anywhere from Panadols, which is very rare, I must admit. By the time patients come and present to me with endometriotic pain or dysmenorrhea, they need something more than Advil.
For sure.
And this is one of the areas which, for example, I've even gone as far as introducing medicinal cannabis to some great success with some patients with regards to dysmenorrhea.
Let's talk about medicinal cannabis and your support for it.
With medicinal cannabis, I must admit, it started for me when I had a patient who came in to see me, and she had been to 8 specialists for pain. She had a malignancy. She was in the end stage of her life. She had seen 4 specialists here in Barbados and 4 in Canada. And she was upset because her quality of life, she accepted the fact she was going to die, but her quality of life had crawled to a almost halt where she was basically waking up and lying in bed. It was a miracle that she even came to my office. And for want of a better term, I basically looked at her and went through her clinical presentation and realized that almost every single drug had been tried. And the only one that had not been tried had been cannabis. So at the time, we will wink, wink. I was unsure of the regulations about it, but I later found out that I was perfectly within the regulations. We decided that she would try some ganja tea. And lo and behold, by her 3rd visit to me, she was thanking me because I didn't expect necessarily to see her again. But she came back in, she walked in, that was the first thing. She sat down and she was thanking me that she was able now to get back to gardening. And she was actually living a fuller life than she had lived before. But however, she was still, because of the stigma, even her husband didn't know she was on it.
Yeah.
And then, of course, came that famous case of Mr. Douglas Trotman and his wife. They came after that case, and under his advice, which was found to be sound, I discovered that the law stated that a doctor can prescribe cannabis once it's used for medical reasons. I can't remember exactly the year, but I think it is 1993. And it was with that I wrote the very first cannabis prescription for Kathy Ann Trotman. And I must say I was glad to hear that it helped, because I think she too had become frustrated with taking the normal allopathic or normal medications that are expected, allopathic being customary medications. And then from there, that's when it started to really take off. I started to notice changes in patients not only with cancer, but patients who've had the run-of-the-mill of pain medications. And then it started to get excellent results. Because one of the first things that happens when you have chronic pain is that a lot of people, because no longer are you focusing on living life, but you're now focusing on the pain.
Yeah.
And as a result of that, the patients were losing simple things that you and I would take for granted, like sleep.
Yes.
And the first thing that the medicinal cannabis used to do is help them to sleep. Once anybody can sleep, they can escape the horrors of pain. And as a result of that, then they were able to better cope with it. And wouldn't necessarily decrease the intensity at all purposes, but it would definitely help them to cope and give them coping mechanisms.
So in terms of the conditions you're treating here, in terms of pain management, are you prescribing medicinal cannabis for most of the conditions? I just want to understand you correctly.
Well, it depends on what conditions you have. If you have, for example, we went through fibromyalgia, for example, and fibromyalgic patients, then one of their biggest complaints I've found is that they're tired all the time and they're not getting a good night's rest. And I find using the medicinal cannabis in the oil form sublingually, anywhere between 2 to 25 drops, helps them to sleep at night. And they are able to, they'd say that their pain levels start to drop. Now, with regards to patients who are osteoarthritis, rheumatoid arthritis, I tend to look at topical versions of cannabis. There are some lotions out there that work extremely well, the tissue gels. And if you apply them 3 times a day, a lot of my patients have come back and said this works. I've even tried it, and patients have given me favorable responses with diabetic peripheral neuropathies, which is something which is very common but not often complained about, which is the issue here being that patients don't quite understand what the pain is. With diabetic peripheral neuropathies, what we as the medical professionals view as neuropathic pain, the diabetic may call numbness or altered sensation, but we term that medically as pain, even though it is, technically speaking, they're feeling numb.
And you also offer traditional Chinese medicine here. I was surprised when I went to the services and saw that.
Oh, we're very, very excited about that. I must say that started initially with the first Chinese mission here to the hospital. As you know, the hospital has a relationship with Chongqing Hospital in China, or hospitals. There's so many hospitals in China. But yes, but one of the hospitals of traditional medicine in Chongqing. And our very first Chinese doctor, Dr. Eric, came down here. And I had known about acupuncture through my training, because as I tell everybody, in 1971, a New York Times reporter got appendicitis in China, and they were able to remove his appendix without putting him under anesthesia, just using acupuncture. And he wrote about it, and that's how acupuncture became popular in the West. So I was anxious to try it, okay? And given the fact that we see a lot of chronic pain patients over here, and a lot of them are fed up with taking medications all the time, it was providing another non-medication route for the treatment of pain. And Dr. Eric came here. We started with a few patients at first, and then by the time he left, he actually was getting, I think he had 2 or 3 offers of marriage, for want of a better term. But he was so successful that people wanted traditional Chinese medicine offered here as a result of that to treat their pain. And that includes things like the cupping, which is where they use heated cups and they put it over your back and it causes the muscles to relax, as well as acupuncture and something called moxibustion, which is where you use heated sticks and place them close to the skin. Again, putting superficial heat in areas and causing muscle relaxation. So we've had great responses from that. And I must say that there are a lot of patients out there who are, for want of a better term, fed up of taking medications. And so traditional Chinese medicine, I see that going for a long time. And you know that it is successful when you start getting your own colleagues calling you up and saying, book me in for the traditional Chinese medicine. But I said, but hold on, he's left. No, we'll get him back in. Just do it. And so if you see doctors using a form of treatment, then you know that
it works.
It works.
Yeah. Well, speaking about work, thank you and your team. Kudos to your department for all of the work that you are doing. And I'm sure Barbadians are a little more enlightened because we were not aware of all of the services being offered here in your department.
Well, thank you once again for having me. And as I said, there are other services here, but I gather that another day, another time. But thanks again, Lisa.
You're most welcome. That was the head of the Rehabilitation Department here at the QEH, Dr. Harley Moseley III. I'm Lisa Lord. You are watching 101. Do have yourself a wonderful evening.